Good evening, everyone. So we'll continue our discussion on drugs in dermatology. And I thought that after completing a series of videos on retinoids and on acne pathomechanism last week, let me just take a break and take care of one drug which is not that much routinely used. Personally, I have started using colchicine for the last 2 years or so in various inflammatory disorders, and I found it to be well tolerated by the patients, and it does the job. It does take care of all the inflammatory pathology. So I thought, why don't we take some time and discuss this drug? I did receive a lot of requests regarding colchicine, and I thought let's just take this week and get this drug over with. And the reason that most of us do not use colchicine is because they don't have experience with colchicine, isn't it? We don't see our seniors using this drug very often, and because of that, we don't. We somehow land up in a habit of not using drugs which we are not familiar with. And in the end, that is the reason why I'm making these kind of video lectures, so that we are more familiar with the drugs that we use. And using drugs as a background, we can understand better about the pathologies of skin diseases, isn't it? So, without much further ado, let's start a discussion on colchicine in dermatology. Now, colchicine is actually a natural toxic compound, and it is extracted from a plant, and the plant comes from the lily family. Let me just draw a straighter line. Yeah. So the plant actually comes from lily family, and the scientific name of the plant, and that's a good quiz question if anybody would like to include this as a quiz question. So it comes from a lily family, and the scientific name is Colchicum autumnale, okay, or Colchicum autumnale, okay. So here we can see these are the two pictures, and look at this beautiful flowers. So these are flowers of the colchicine plant, and the colchicine plant is also known as, in vernacular terms, autumn crocus, meadow saffron, naked boys, and naked ladies. The reason it is known as by the name naked is because the flowers appear first out of the ground before the leaves start sprouting, and that's why the flowers appear naked. Okay, so that is the reason. It's a very good tidbit which I wanted to share. Now, from the plant, the drug is extracted, and this drug is actually very toxic. It's toxic to humans and animals, and there have been multiple cases of people developing toxicity because they eat this plant in the wilderness. Because the bulb of the plant, the area which is just under the ground, it looks a bit like garlic, so they have a tendency to eat that or use that into cooking, and leading to colchicine toxicity. Okay, so this could be a good quiz question. The scientific name of the plant through which colchicine is extracted. So it's Colchicum autumnale. Let's move forward. So colchicine is a naturally occurring alkaloid, and it is FDA approved for use in gout or gout flares, not exactly gout, but during flare-up periods, as a maintenance therapy in familial Mediterranean fever, in various rheumatological disorders in which you have joint pain and inflammation, and in CVS cardiovascular diseases. So much so that it has been used as a good maintenance agent because of its good cardioprotective effects. So people taking very low quantity of colchicine for longer duration of time, nearly their entire life, have good cardiovascular outcomes. So that has been described. Okay. Like all other drugs in dermatology, we take this drug from rheumatology and cardiovascular sciences and use it in our disorders or our dermatosis. Mostly it is used in oral form as a form of tablets. There is IV form available, but it is not used because the side effects are significant with the IV preparation. Additionally, the most common adverse effect is gastrointestinal side effects like nausea, vomiting, and diarrhea. And if you give it IV, the drug bypasses the GI route, and you don't see the most common side effects, and you see the rarer side effects which are much more serious, like cardiovascular toxicity, arrhythmias, blood dyscrasias. So because of that reason, the IV formulation is not used nowadays. Oral is the most common formulation in which colchicine is available. Other formulations topical, it is available as 1% topical gel. There have been instances of 0.5% topical gel that has been there, and this is the newer modality. of topical agent as 1% or 0.5% colchicine gel. Normal doses range from about 0.5 to 2 milligram once a day, twice a day, or 3 times a day. Sometimes you can go as high as 4 times a day. Okay, it has been approved after the age of 4 years, and mostly it is in familial Mediterranean fever, in which you give a longer duration of doses. And in pediatric cases of familial Mediterranean fever, more than 4 years away, it has been regularly used. There have been isolated case reports of use of colchicine in less than 4 years of age, but these are just case reports, so no proper studies are there. But it has found to be substantially safer in more than 4 years of age. As I said, that it's a naturally occurring alkaloid. It's a lipid-soluble alkaloid, and it is rapidly absorbed from jejunum and ileum on oral intake. So if you take the tablet, it is rapidly absorbed from jejunum and ileum. The half-life ranges to about 20 to 40 hours. There have been few articles which mention 23 to 30 hours. So you can just write 20 to 30 or 40 hours. Okay. The bioavailability is variable. It ranges from 18 to 79%. Mean is 45%, which many articles mention. So if you want to answer one answer, then bioavailability is 45%. Otherwise, it is a range. Why colchicine has a range of bioavailability, or why the bioavailability is variable, we'll understand when we will be understanding the mechanism of action. The protein binding is significant, mainly albumin. The drug undergoes extensive first pass metabolism, and the metabolism is via CYP3A4 enzyme by the process of demethylation. Just remember that CYP group of enzyme, mainly CYP3A4, is essential for the metabolism, and all the inhibitors of CYP3A4 will lead to increase in doses of colchicine, leading to more toxicity. Okay, and all the inducers of CYP3A4 will decrease the levels, leading to less therapeutic effect. Okay, excretion is mainly through the bile secretion, through the bile excretion and the feces. 10 to 20% is through the urine. Okay, so majorly it is a hepatobiliary excretion. No, the way colchicine act is by binding to the microtubule architecture in the cytoskeleton, along with the inhibition of CYP3A4, or at least binding to CYP3A4, and binding to P glycoprotein or glycoprotein P. So if you want to write a note on mechanism of action of colchicine and to understand the way it acts, so you have to mention that majorly it acts by binding to tubulin and microtubule architecture, but it also binds to CYP3A4. That is how it undergoes metabolism, and it also binds to P glycoprotein. It is very important to understand this binding, because any other drug which will influence this binding, or which will influence the metabolism of colchicine via CYP3A4, will lead to toxicity. Clear? Now, P-glycoprotein is actually a transfer molecule. Okay, it's a transfer molecule, and it is found in various different kind of cell populations, like enterocytes in the intestine, hepatocytes in the liver, kidneys, even in blood-brain barrier. So this P-glycoprotein is responsible for different transportation of molecules inside the cells. Okay, so when colchicine binds to P-glycoprotein, this transportation of the molecules are affected, and because of that, you see the different kind of side effects. Okay, now because of this variable binding to these entities, tubulin, CYP3A4, P-glycoprotein, the plasma concentration is also variable. And since the plasma concentration becomes variable, the response is also variable. So when we'll be discussing the uses of colchicine in dermatology, you will keep on hearing that in some diseases it is very good, modest benefit, low side effects, while in some other disease it has high side effects, not that much beneficial, even if the pathomechanism is somewhat similar of both of these diseases. Okay, that is because of different action on different attachment molecules. These attachments also affect the drug-drug interaction. Like we have said, any inhibitors of CYP3A4 will increase the quantity of colchicine and will increase side effects. In elderly, there's increased volume of distribution, so the chances of toxicity is more. It's better to use lower level of drugs, lower threshold of colchicine. And additionally, there is more chances of hepatic or renal impairment in elderly. So it's always better to start a lower dose of colchicine or maintain on that, okay? And keep monitoring for liver and kidney damage. Mm. Okay, so after discussing about the pharmacokinetics or pharmacodynamics of colchicine, we'll discuss shortly regarding the mechanism of action. Colchicine is a good drug as an immunomodulator. Why? It gets concentrated in leukocytes. It is said that plasma concentration, you could say around 40 times concentration of colchicine is more in leukocyte as compared to plasma. Somewhat like that. I don't have a reference for that. I think I read it in an article. And in fact, the accumulation of colchicine is very much inside the leukocyte, and that is the main reason why you see the immunosuppressive or immunomodulatory effects of colchicine, because majority of the drug resides inside the inflammatory cells. Okay, it interferes with the migration and degranulation of inflammatory cells. That is how it is immunosuppressive or immunomodulatory. There is inhibition of microtubule polymerization. Remember a few slides ago, I told you that it binds to tubulin. Now tubulin, so if I just recap it, you have a cell, okay, and a nucleus. You have a lot of intermediate filaments, microtubules inside the cytoplasm. And these microtubules act as roads or railways inside the cell. And kinetic motors are organelles or molecules which are supposed to carry organelles, carry secretions, carry products all over the cell. Okay, so they essentially walk on microtubules. When this microtubule polymerization, that is the laying of microtubules, is inhibited by colchicine, these secretions, these products are not able to reach effectively to their destination. When they are not able to reach effectively, the cell ceases to act. And that is how the immunosuppression effect takes place. Okay. So essentially, there is inhibition of microtubule polymerization and incorporation into the cytoskeleton. The tubulin colchicine complex, that is the complex of colchicine along with the tubular architecture, inhibits the elongation of microtubules. That is what I said, inhibition of microtubule polymerization. Because of this, the spindles are not formed. There is no mitotic spindle formation and no cell division. Now remember your basic biology. In the metaphase stage, you have the lining of chromosome at the center, at the equator. You have the polar bodies, and then you have these attachments. Okay. Now these attachments, what will happen during the further stages of cell division is that these attachments will attract or pull the chromatin material separately or chromosomes separately. These attachment threads, okay, and I'm talking about these threads, these are made by microtubules. If these microtubules are disrupted because of colchicine, the cell division doesn't happen. And that is how colchicine impacts the proliferation of cells. Now, since colchicine is actively incorporated and concentrated in leukocytes, the leukocytes are not able to divide. So now you have the suppression of leukocytic proliferation leading to suppression of inflammation. We are clear on that? Let's move forward. Because of disruption of tubular architecture, the intracellular motility, secretion of endogenous mediators like cytokines and chemokines are all inhibited. So the products that the cell makes, the inflammatory cytokines like TNF-alpha, interleukin-1, so all of these cytokines which will cause inflammation, the cell is not able to perfectly transport it at their location because of microtubule disruption. And that is how these secretions, these chemokines are also reduced, leading to immunosuppressive side effects of colchicine. I'm clear on that? Let's move forward. Majorly, the action of the action of colchicine was more on disruption of tubular architecture. Okay, but it has been changed or it has been researched or learned that the action on the anti-inflammatory aspects is significant. So as I've said, that colchicine accumulates in much higher concentration in leukocytes. And leukocytes are the key mediators of inflammation. So the anti-inflammatory effects is somewhat concentrated. Okay. What colchicine actually does is it inhibits cell adhesion, migration, and signaling. Remember the process of diapedesis. Diapedesis. This is the process through which inflammatory cells migrate to the edge of the blood vessel and through the cells through the cells and reach the skin. This is the process of diapedesis or reach the end organ, isn't it? For that process to happen, the inflammatory cells need to attach to the blood vessel wall. Okay, so let's say you have endothelial cells here. This is the wall of a blood vessel or capillary. Okay, and you have an inflammatory cell here. Okay, the inflammatory cell will first attach, A for attach. Then the inflammatory cell will roll, R for roll, it will roll, and then it will squeeze through the gap, S for squeeze. Okay, it will squeeze and then reach the end organ. End organ. Okay, this process is essentially diapedesis. So colchicine inhibits the adhesion of cell, migration, and also the intercellular signaling. And because of that, the inflammatory cells are not able to reach properly to the end organ destination, and the inflammation is decreased. So there's decreased initiation and amplification of inflammation. I'm clear on that? Colchicine also inhibits cyclooxygenases like COX-1 and COX-2, and these are all mediators of inflammation. Okay, these are all prostaglandin pathway, for inhibition of inflammation. Now we know that in any inflammatory disorder, the first cell to reach is neutrophils. First cells from the peripheral blood to reach the site is neutrophils. And colchicine inhibits the migration of inflammatory cells. So it will also inhibit the migration of the first inflammatory cells like neutrophils. And neutrophils are very fast acting cells. They are the first one to reach. So that makes colchicine very useful in neutrophilic disorders like psoriasis, LCV, and urticarial vasculitis. We'll discuss the uses in detail, don't worry. So in this diagram or a pictorial representation, we will summarize the action of colchicine. So you have colchicine, okay, you have colchicine here, and it will lead to disruption of tubular architecture. Disruption of tubular architecture. This is the tubule. I told you, right? It looks like a railway track, and the motors move on that so that to carry the products in the cell. Okay. Now, tubules are important for cytoskeletal rearrangement, for cell division and mitosis, for phagocytosis, for intracellular transport, and everything is inhibited by colchicine because of disruption of tubular architecture. Clear? Colchicine also inhibits inflammasome formation. So inflammasome I would not say new. We know about inflammasome for the past, let's say, 8 to 9 years or 10 years. But it's an important mediator of inflammation. Colchicine inhibits inflammasome. Okay, and when inflammasome is inhibited, inflammation is inhibited. Inflammation is inhibited. Action of colchicine on other inflammatory cell lines are like this. So in neutrophils, chemotaxis, adhesion, mobilization, reactive oxygen species production, L-selectin shedding, all are decreased. Now L-selectin is responsible for attachment of neutrophils, okay? All are decreased by colchicine. For lymphocytes, activation of lymphocytes, and TNF alpha expression, interleukin 2 receptor expression, all which leads to inflammation are also decreased. In monocyte and macrophage, TNF alpha, TNF receptor, ROS production, L-selectin, all are decreased. In platelets, shape change and aggregation, that is why the coagulation is also affected. And that is why one of the important side effects of colchicine is actually coagulopathies. Okay. In endothelial cells, which is the edge of the blood vessel, E-selectin, the cellular signaling, LOX, all are decreased because of colchicine. Smooth muscle proliferation, migration, endocytosis, and metabolism all are decreased, and that is why you have myopathies as a side effect. Okay, or one term that I've read recently, sarcopenia. Okay, so myopathies are important side effects of colchicine, and that is the reason why, because colchicine is inhibiting all of this in smooth muscles and also in skeletal muscles. Okay. Now, this diagram is to show more the effect of colchicine on inflammatory cells like neutrophils. So, in neutrophils, there's inhibition of all the L-selectin molecules. L-selectin is responsible for attachment of neutrophils and migration. Clear? So, there will be no migration of neutrophils or less migration of neutrophils. Now, phagocytosis, inflammasome activation, caspase-1 activation are all inhibited by colchicine. So less inflammasome, less inflammation. All the chemotactic factors are inhibited by colchicine. So no chemotactic factors, no calling of the inflammatory cells. So all of this, it is just to summarize what all colchicine is doing. If you have to write a note, then major action is tubular disruption. Other is inhibition of chemotactic agents, inhibition of attachment of cells like neutrophils, inhibition of activation of T cells, inhibition of inflammatory mediators like TNF alpha, okay, inhibition of attachment of inflammatory cells, inhibition of diapedases, okay, inhibition of inflammasome, inhibition of platelet aggregation. So only by using these two diagrams, you are able to understand easily how colchicine acts as an immunomodulator. Let's move forward. So we have discussed the pharmacology of colchicine. We have discussed the mechanism of action of colchicine in detail. Now we'll quickly go through the uses. Now remember, there is no FDA approved use of colchicine in dermatology as of today. All the drugs, or sorry, all the diseases that I'll be discussing are isolated case reports or few case series or some of the studies, prospective, retrospective, but no proper RCTs have been designed. So there's no good evidence of usage of colchicine. Okay, so we'll just name the disease and the effect of colchicine in that disease. That is how we're going to go through it. So first disease is chronic urticaria. First is chronic urticaria, which is recalcitrant to usual therapies. Usual therapy means it is not responding to antihistamines or corticosteroids. Let's say you have a patient of chronic urticaria who is steroid dependent. The moment you decrease the dose less than 10 or less than 20, hives appear. So then colchicine becomes a good drug to add as a steroid sparing agent. Okay, so colchicine can be used to decrease the dependency to immunomodulatory drugs and steroids, to decrease the doses required or the dependency of the patient to those drugs. Doses roughly about 1 to 1.2 milligram per day. Level of evidence is 2 and 3. We'll discuss the level of evidence few slides afterwards. Don't worry. Second use is cutaneous vasculitis. There is conflicting evidence, but colchicine has been used in multiple patients to reduce the amount of steroid doses that the patient is taking. Few studies have said that colchicine can be as effective as steroids. And remember, colchicine is a fast-acting drug. The half-life is 20 to 40 hours. It is rapidly acting. So you can use in, let's say, milder cases of cutaneous vasculitis or cases of CVs in which the patient is dependent on steroids, you can add colchicine to decrease the dose of steroids, maybe even stop steroids. Okay. Response may persist after stopping in some of the patients, but relapses were very common after stopping. And relapses take about 3 to 4 months to occur. It is variable in patient to patient, disease to disease, but relapses are a known problem with colchicine that the moment you stop, relapses happen. The third is palmoplantar pustulosis in the group of neutrophilic disorders. Remember, I said that the colchicine is a good drug to be used in neutrophilic disorders. The first of which is palmoplantar pustulosis. The dose is 1 to 2 milligram per day. Good responses, but again relapses on stopping. The article mentions modest benefit, but at the expense of high rate of side effects of colchicine. So you have some benefit, you have some modest benefit, but the rate of side effects is very high. Fourth is psoriasis. Psoriasis again shows modest benefit with the oral drug, but there are studies which have used 1% topical colchicine with good improvement of recalcitrant plaques. So if there are plaques which are not responding to, let's say, topical corticosteroids, topical coal tar application, or any other topical agent, and you have few area of involvement, let's say body surface area 1%, 1.5%, 2%, you may consider using 1% topical colchicine provided you have access to topical colchicine. Okay. So colchicine can be used in mild cases, but not so much in severe cases. It's better to rely on other immunomodulatory drugs like methotrexate or cyclosporine. Okay. Let's move forward. Fifth is pyoderma gangrenosum. Again, in neutrophilic disorders, 1 gram once a day has been used. Diseases which was refractory to other modalities like steroids, like infliximab, like dapsone, you can start using colchicine if the patient is tolerating. Good response was seen in roughly 2 weeks to 3 months. So most of the time it takes around months to show good response. Okay, so it's a good idea. Let's say you have a patient with severe pyoderma gangrenosum and there are no contraindication to any of the drugs. Start steroids, make it manageable, maintain on colchicine. Okay. Sixth is sweet syndrome, which is again a part of neutrophilic dermatosis, 0.5 milligram 3 times a day. Good response was seen in skin and the systemic symptoms like fever or weakness. There was good improvement in systemic symptoms also in within a week. So it's a very fast acting drug again. Okay. So the response starts early. It just depends on how many months or weeks you can maintain the patient on colchicine. You can give colchicine as long as the side effects are not appearing. Okay. I forgot how many drug diseases we have done. Let's just say 1, 2, 3, 4, 5, 6, 7 is dermatitis herpetiformis. Again, neutrophilic dermatosis, zero point 0.6 mg 3 times a day, 4 times a day. Modest benefit, but high side effects. Okay. Eighth is epidermolysis bullosa acquisita. Okay. 2 milligram a day has been given. There has been a good response in 2 weeks with clearance in 2 months. But again, the moment you stop, the disease starts to come back. Ninth is mucous membrane pemphigoid, in which the dose of 1 to 1.5 milligram per day, along with steroids. It's a good drug to act as a steroid sparing agent for maintenance. Now, in MMP, what essentially happens is there's increased scarring, there's increased inflammation. So, it's a good idea to start with a good amount of steroids, effectively acting dose of steroids. You control the disease and then keep it controlled by using colchicine. Clear? That is how you're supposed to act if you want to control a severe disease. You give steroids, make it controllable, maintain on colchicine. Okay. 10th is subcorneal pustular dermatosis. Again, neutrophilic disorders. 0.5 milligram twice a day. Good agent for resolution and maintenance. So what we have learned from this discussion that colchicine is a good maintenance agent for maintenance as a steroid sparing agent as a steroid limiting agent. Now, what do we mean by limiting? Decreasing the dose. Okay. So, you can wean off your patient earlier. You can decrease the steroid doses earlier if you also start colchicine along with that. Okay. So, that is a good way to manage your patients by using colchicine. Now, others like hidradenitis suppurativa, no benefit, major side effects. Acne vulgaris, limited evidence. Recurrent abscess stomatitis, good agent, good response quickly within days. Actinic keratosis. Now, in actinic keratosis, topical agent was used, topical colchicine gel, 1% to 0.5%. Good inflammatory response initially, but when the inflammatory response clears up, there was clearance of lesions. But again, if you stop using, the actinic keratosis is a disease which will reoccur if you don't have other protective measures. So again, relapses were common. Erythema elevatum diutinum, a good second line agent when dapsone cannot be given. Dapsone is a very good drug to be used in EED, but if let's say the patient is developing hemolytic anemia or the patient is anemic, you can consider using colchicine in those cohort of cases. Okay. And these are all different diseases, all case reports, only, one patient, two patient case reports in which they show good benefit with colchicine as a maintenance agent. Disorders include cutaneous sarcoidosis, cutaneous amyloidosis, pigmented purpuric dermatosis, majorly the granulomatous variant, erythema induratum, erythema nodosum, acquired perforating dermatosis, linear IgA disease, pemphigus vulgaris, fallacious, hereditary angioedema. Apart from that, I have used in few patients of lichen planus and also in prurigo, both simplex and nodularis variety, and dermatitis herpetiformis. These are some patients in which I have used as a good maintenance agent. Okay, even in EB pruriginosa, I've used in one patient, female patient of reproductive age group. Otherwise, I usually prefer thalidomide in EBP. So I have given you a list of roughly nearly 15-20 disorders of individual case reports. You can easily write a list of disorders in which colchicine has been used. Most of the time, it is a good maintenance agent, and you can limit the use of steroids in your patients. Okay, let's move forward. Now, these are the different levels of evidence regarding different dermatoses along with the grade of recommendation. Higher the level of evidence, more is the better is the drug suited in that disease. The 4 means anecdotal evidence. That means only few people have tried and found to be benefit. They don't have done properly designed studies. Okay. The higher evidences is usually seen in HS or acne, in which the evidence is level is good, but the recommendation is very low because it has not shown that benefit. Okay, so that is how you interpret this data, that if the grade of recommendation is high, that means colchicine is working, it is good, you can use it. And if the level of evidence is high, that means the study which was done was good. Okay, so if level of evidence is high, trust the grade of recommendation. If it is low, there's no point in trusting the grade of recommendation. Similarly, similarly in other disorders like erythema indolatum, amyloidosis, see all is sorry, the level of evidence is 4. 4 is anecdotal evidence. That means isolated case reports, that's all. Okay. So even if the grade of recommendation is C, take it with a pinch of salt or at least a kg of salt, that you might you can use colchicine in rarest of rare circumstances. Okay. Let's move forward. So we have discussed the list of disorders in which colchicine has been used. And again, I would request you to repeat after me. Colchicine is a good maintenance agent, safe maintenance agent, decreased dose of steroids and other drugs, limit the use of steroids in your patients, quick response, it happens in weeks, 1 or 2 weeks, and you can easily monitor the side effect profile. So that makes colchicine a good second line or a good maintenance agent in various other disorders, various the inflammatory dermatosis. Okay. Now, after discussing all of this, let's come to the adverse effects, and these are very important. If you know about the adverse effects, it makes you better suited to use that drug. When to use a drug is important. When not to use a drug is more important. Okay? So the most common side effect is GI side effects, including nausea, vomiting, diarrhea, happens in about 5 to 10%. Diarrhea can be as high as 23% in one article. Okay? And these are early occurring side effects within less than first day. Other side effects are rarer, but they are much serious. Okay, renal failure, bone marrow suppression, arrhythmias, and heart failures have been reported, and these are all serious adverse effects. Acid-base imbalance, coagulopathy. Remember, I told you about the platelet aggregation inhibition by colchicine. Neuromuscular disturbances because muscles are also less. Their inhibition of muscle activity is also there. Inhibition of glycoprotein is there, which is seen in blood-brain barrier. Now you see why the mechanism, if you know about the mechanism of action, you can easily understand or easily remember the adverse effects. Blood dyscrasias like leukopenia, granulocytopenia, thrombocytopenia, pancytopenia, plastic anemia. Okay, bone marrow suppression is a very important side effect to look forward. Okay, so while you're getting all those blood tests done, always evaluate for bone marrow suppression. Pharyngolaryngeal pain has been reported in about 3% of the patients are taking colchicine, so I decided I'll just mention it here. Drug interactions. Now, drug interactions is very important. Why it is important? Remember, it attaches itself to glycoprotein P and metabolized by CVP3A4. So any drug which inhibits CVP3A4 will not allow colchicine to be metabolized. If colchicine is not metabolized, the quantity of colchicine will increase in the system, and if the quantity increases, more are the side effects. Clear? So if more than us, or if any other drug is ongoing in the patient, you can have risk of toxicity at lower doses. So drugs like antibiotics, including clarithromycin, erythromycin, which are all CVP3A4 inhibitors, antifungus like fluconazole, itraconazole, ketoconazole, calcium channel blockers like diltiazem, verapamil, immunosuppressants like cyclosporin, tacrolimus, statins like atorvastatin, simvastatin. All of these drugs will inhibit the CYP3A4 enzymes and may increase the plasma concentration of colchicine leading to increase in side effects. Clear? Now you understand the concept? Additionally, statins can cause muscle damage as their own side effect, and myopathies are being caused by colchicine also. So you are actually increasing the risk of myopathies if you're using colchicine in a patient who is already on statins for any other reason or any other department. Okay, now you understand the various drug interactions, easy to remember. Let's go forward. Dose reductions. Reduce the dose in two kind of patients, those who have renal failure or hepatic impairment. Now, if the creatinine clearance is between 30 to 50 or more than 50, no dose reduction is technically required, but you have to monitor closely regarding the side effects. If it is less than 10, you cannot use it. So if the creatinine clearance is less than 10 ml per minute, no colchicine. Okay? No colchicine. Because colchicine itself can cause renal damage and 10 to 20% of colchicine is excreted through urine. Clear? If there's hepatic impairment, remember majority of the excretion of colchicine happens as through hepatobiliary route. So you have to monitor closely. Dose reduction is as such not advised, but you start with the lower dose and gradually increase so that you limit the side effects. Okay. Keep drug interactions in mind because if drug interactions happen, there are more chances of toxicity and side effects. So keep the drug interactions in mind. Okay. Toxicity. Now, it is important to discuss toxicity of colchicine is because of the very reason of toxicity is the reason why we don't use colchicine. Let me repeat myself again. Colchicine is a very toxic drug. If you remember the first slide of this video, I told you that the plant Colchicum autumnale is toxic to humans. And because of the toxicity of colchicine, most of the seniors don't use it regularly, and as a result, the juniors don't know how to use it. Okay, or they are afraid of using because they've heard stories about toxicity. And I agree, it's a very toxic drug. So it is very important to understand this drug so that we can use it. We can have one more drug to treat our patients. Okay. So colchicine has a narrow therapeutic index. That means the level of drug in which so what exactly is therapeutic index? It is the level at which clinical efficacy starts and the level at which toxicity starts. The difference between these two levels is the therapeutic index. That means the interval of doses in which you can use the drug safely. If you use it less than that, there are not much good clinical effect. If you use more than that, then more the side effects. Clear? So that is therapeutic index. It has a narrow therapeutic index. That means these two levels lie very close to each other. So you have to be very careful in using drugs with narrow therapeutic index. Okay. If anyone know about other drugs which have a narrow therapeutic index, please write that in the comment section. Let us have a list of drugs which have very narrow therapeutic index in skin so that we are more careful. The lowest reported lethal dose was about 7 milligram over a 4-day period. Okay. The LD50 dose of in mice, that means the dose required, the oral dose required to kill 50% of a mice population was found to be 5.87 milligram per kg. And of course, these kind of doses are not available for the adult section because of variable bioavailability. So a dose which is tolerable by one patient can be easily lethal in another one. Okay. Now there are essentially two stages of colchicine toxicity. The first is begins in less than one day and starts as GI symptoms like nausea, vomiting, diarrhea, volume depletion because of increased fluid loss, and peripheral leukocytosis. So that these are the three factors which appear early within 24 hours. Okay. After that, the body goes into a life-threatening stage in 24 to 72 hours after ingestion, and because of multi-organ failure, the outcome is usually fatal. Respiratory depression can occur, cardiovascular collapse can occur, leading to a bad morbidity or mortality outcome. Okay. Now, the most problematic thing about colchicine is that even in toxicity, the dialysis process is not effective. You cannot effectively remove the drug in case of toxicity. The management relies mostly on gastric lavage, that means removing the intake of drug, managed shock, manage all these symptoms so that treatment remains symptomatic, so manage all the symptoms. There is no available antidote to colchicine toxicity. So if you want to prevent these kind of mishaps from happening, start from the lowermost doses. I use 0.5 milligram twice a day, depending on inflammatory response. Then maybe the highest dose that I have used is 1 milligram twice a day. I've never gone higher, and that has been found to be effectively controlling the disease. Then why should I go higher? And I keep an eye on different kind of toxicities or side effects that can occur. So keep on monitoring your patient regularly and keep on titrating the dose so that the response are met and the side effects are limited. Clear? But you have to be wary of toxicity of cortisone because multiple drug interactions are there. Okay, so you just have to be knowledgeable about it so that you can prevent it. Clear? You don't have to be afraid of any drug, you just have to be knowledgeable for that drug. Okay, let's move forward. So in So in pregnancy and lactation, colchicine is pregnancy category C. That is very easy to remember. C for colchicine. Okay, so pregnancy category C. Remember, these are older FD category. The newer ones don't have letter designations. Colchicine crosses the placenta, so it reaches the fetus, the growing baby. It is excreted in lactation, excreted in milk, can cause side effects, so you have to monitor infant. Although the various articles that I have read, there were no reported cases of serious side effects in the infant if the mother was taking colchicine. But since the body size is so small, even lower doses can cause side effects. There is excretion in breast milk. It's just better to monitor the infant if giving colchicine is important to the mother. Okay, there will be no known effect on fertility as of now. Okay, let's move forward. Okay, so that actually essentially finishes the presentation. And let me just recapitulate what we have learned so far. Colchicine is a good steroid sparing agent. It works by disrupting the tubular architecture and by decreasing the inflammatory mediators, inflammatory cells, inflammatory adhesions, decreasing inflammasome, thereby decreasing inflammation. Okay. Usage is mostly in neutrophilic disorders like psoriasis, palmoplantar pustulosis. I have used in lichen planus, prurigo simplex, prurigo nodularis, EBA, dermatitis herpetiformis. Let's just say in all the disorders in which you can safely use dapsone, you can use colchicine as a second line drug. Side effects include majorly nausea, vomiting, diarrhea, followed by rare and important side effects like blood dyscrasias, coagulopathy, arrhythmias, heart failure, renal failure. Okay, and if you have to limit the doses in renal failure, hepatic impairment, elderly diseases, if you're giving it in children, so you just have to use lower doses and monitor for side effects. Okay, these are some reading recommendations, but you will not require them if you go through this video only. It's just that if you want to know things in much more detail, you can go to the individual article. Always start by reading the product insert. Colchicine and dermatology gives you a good overview about the uses. You can read any one of these two articles. These are more or less same. And if you want to read in detail how does colchicine actually work, read any of these two articles. These are very good articles to understand the working of colchicine. But this whole video is actually enough at residency level for you to understand this drug. So with that, we finish our discussion on colchicine, a shorter video. But I wanted to do colchicine because there are drugs which are not so much used in our daily practice. Even in institutional setting or in medical college settings, we don't use colchicine that much like we would have used methotrexate or azathioprine. So the main reason that we don't use colchicine is because we have less experience in using colchicine, and you end up in a vicious cycle. You have less experience, so you don't use colchicine. You have less experience. Okay, so this kind of cycle is going to increase your unfamiliarity with colchicine. I have started using it for the last 2 years. I've used it in lichen planus, good response, Prurigo, good response, EBP, good response. In all of those patients, colchicine was never the first line drug. It was always used as a maintenance agent if the disease was responding to steroids but not maintained off steroids. Okay, so it's better to add so that you can use lower amounts of immunosuppressive drugs and quickly wean off the patient if other immunosuppressive drugs like methotrexate or azathioprine or cyclosporine cannot be used for some reason or the other. It's not that costly drug. The availability is an issue, but if you ask for it, you do get it. Okay, so it's a very good drug to understand the usage of those drugs so that you can help your patients in various inflammatory dermatosis. That makes this video important so that we, with one 40-minute video, we can easily understand the working of colchicine. So with that, I finished this presentation. You can email me any doubts, suggestions, anything to improve. But it's always better that you write everything in the comment section so that other people who are visiting this video after it has been uploaded, they can also learn from your comments, learn from your questions, learn from your suggestions. So all the doubts, suggestions, queries, it's better to write in the comment section. People do usually email me, but emails do get lost, they do get buried inside a lot of emails, it do go to spam folder. Best is to write in the comment section so that I can reply to each one of them. I may be late, but I do reply to all my comments. Okay. So with that, let's finish this presentation. Adios, bye bye, and enjoy your weekend. We'll meet next week.